Hello, my name is Lydia Trippler. I'm a postdoc at the Swiss Tropical and Public Health Institute in Basel, Switzerland, and I'm very happy to present today about wash interventions and mass drug administration for schistosomiasis elimination in Pemba, Tanzania. I'm starting my presentation with showing you the life cycle of Schistosoma hematobium, which is the schistosoma species that transmits urogenital schistosomiasis. The life cycle starts with an infected human being who goes to a freshwater body to enjoy the sun or to wash clothes, to wash dishes, to swim, and then urinates into the freshwater body. By doing so, eggs are released into the water, which then hatch and release miracidia, which then penetrate the skin of the intermediate host snail for Schistosoma hematobium. And then after a process within the snail releases tens of thousands of the carrier into the water, which then can penetrate the skin of the next human being who enjoys also the sun at the same water body. This is how the parasite looks like in the human being after having traveled through the body for around 6 weeks and then ends up in the urogenital system around the bladder, tears up like shown here, and then the whole life cycle starts all over again by the paired adult laying eggs. There are several ways to interrupt this life cycle. One, for example, is here by treating the infected individual. Another one is here by killing the intermediate host snail, or at least reducing the overall amount of intermediate host snail by conducting so-called snail control. And another way is to interrupt the life cycles here by the individuals changing their behavior, which you can make more attractive by doing behavior change interventions. Because if individuals are not urinating into the freshwater bodies anymore, or if individuals find other water sources and don't go to the freshwater body at all anymore, then the life cycle is also interrupted. Our study takes place in Pemba, which is part of the Zanzibar Islands that you see here. And the Zanzibar Islands are located at the East Coast and belong to the United Republic of Tanzania. To give you an idea on how the Zanzibar Islands are, there are around 2.2 million people living on the islands, and around 88% have access to a toilet. But our study took place in the north of Pemba, where only around 44% have access to a toilet, so a lot less. And then electricity access is around 47% of the population of Zanzibar. But again, in the north of Pemba, only 15.7% have electricity at home, so a lot less. Pemba has a very long history of schistosomiasis interventions, and as you can see, those interventions have led to an overall decrease of schistosomiasis prevalence over the last years, and nowadays we do have a very low overall prevalence of around 1%. But we also have a high spatial heterogeneity of schistosome hematobium prevalence, meaning that we have some of those areas here shown in green that have a very low or zero prevalence, while we do still have those other areas here shown in orange that have a moderate to high prevalence. And my presentation today focuses on the question on how do we reach full elimination also in those hotspot areas, which was also one of the questions we had when we started our Schistobreak project in 2020. In Schistobreak, which we did in the north of Pemba, we had annual cross-sectional parasitological surveys in schools and communities. And based on the results of those surveys, we classified the area into hotspot and low prevalence units. And in the hotspots, we implemented a whole package of interventions, a so-called multidisciplinary intervention approach, while in the low prevalence areas, we had a surveillance response approach. However, today, I do focus on the hotspots, so on those multidisciplinary interventions. Before I'm showing you the interventions that we did, I would like to show you the results of our baseline survey that we conducted in 2020 in the communities. And what you see here from yellow to red is the prevalence in the households in the community survey, and the darker the higher the prevalence is. And if you look at this together with the water bodies, all water bodies in the area that we visited, and especially those where we found the intermediate host snail, then you can already see that there's very likely an association between the prevalence and the distance to water bodies with the intermediate host snail. And if you look at this statistically, you see that this is actually true, and that, for example, children who are going to a school that is less than that is less than a kilometer away to water bodies with the snail have a 5 times higher chance of being infected. And we have the same or similar result with an even higher odds ratio in the communities. So now coming back to those interventions that I mentioned before. So what exactly did we do in those hotspots? The Ministry of Health implemented a mass drug administration of praziquantel, which is the drug to treat schistosomiasis, in schools and communities minimum once a year throughout all the years that we did our study, so from 2020 to 2024. And then part of our study was to build those washing platforms that were built around safe water access points, for example, taps or wells, where people could go and wash their clothes or their dishes and still have community with each other without going to the water body to meet there. We also implemented snail control with molluscicides that kill the snails, which is and we used a molluscicide that is recommended by the World Health Organization, and it is very effective, but it also kills fish. So what we did is that we only sprayed those molluscicides when we really found the intermediate host snails. So we were always searching beforehand, and we only conducted snail control at the shoreline. So we would not spray anywhere where individuals wouldn't reach. And what you see here is a school outreach day that we did as part of our behavior change interventions. Other interventions, part of it were community meetings and movie nights. And here in those school outreach days, the children trained beforehand poems and songs and the drama. So it's a very playful way to have teaching about schistosomiasis prevention, schistosomiasis symptoms, so that children, and then also in the movie nights and community meetings, also the community would learn what they can do to prevent to get infected and to infect others. So let's have a look on the results of the prevalence after 1 year of interventions. So what you see here is the prevalence of Schistosoma hematobium in the schools in the hotspot areas. So what you see is that after 1 year of those interventions, the prevalence has decreased significantly. And also in the communities, the prevalence has decreased, although it was not statistically significant. Coming to the end, the needs, what we do need is environmentally friendly snail control. As I said, the snail control that we use is the one that is recommended by the World Health Organization, and it's very efficient to kill the snails and to reduce the amount of snails. But as I also said, it does also kill fish. So it would be amazing to have a snail control method that is as effective as the one that is recommended, but more environmentally friendly. And we definitely need infrastructure investments. So we do need safe water access for everybody. These washing platforms that we built, they are used and people like to go there, but we can only build them around already existing safe water access points like taps or wells. But there are areas in Pemba where there's no tap or well around. So some of those community members don't have a choice but to go to a water body to fetch water for washing clothes, for washing dishes, or also to go there to swim. So what do we need is infrastructure that allows safe water access to everybody on the island. And then a short outlook is that we will see the impact of this big intervention package in hotspot areas and its impact on the schistosomiasis prevalence in Pemba after the whole project is finished, and we can look at 4 years of data. And herewith, I would like to acknowledge our team from the Swiss TPH in Basel and the University of Basel, especially Stefanie Knopp, who has been the project leader for this project, and our team in Pemba and the Ministry of Health, who are fabulous and are actually doing most of the work, and the Swiss National Science Foundation for funding this project. And all of you, and thank you very much for your attention.